Anybody give me a shout out from what they were talking about? Who wants to kind of contribute?
I think there were a couple of things. I thought, or we thought, there's a danger of thinking in silos, and where the presentations have been excellent, but we also ought to acknowledge the existence of organisations like Marie Curie and Macmillan, who, as far as I'm aware, play a very important part in palliative care.
I think certainly agree with that, and obviously Marie Curie with their hospices would be linked into Help the Hospice UK, but also, again, yes, acknowledging the extensive work of Macmillan in this area is important.
Especially the home visit side of it.
Yeah, absolutely, and the specialist services linked with that.
Yeah. And the second thing that was raised was addressing the issue of babies that died without, stillbirth, the bereavement. I know special kind of counselling for that. That's that we need to be conscious of as well.
Sure, and I think sometimes local services do that well, but I think that may well be patchy as well around the country. But I think I was impressed with the Sue Ryder presentation about that online feed-in, but they did say it was for adults over 18. I don't know whether it would include adults over 18 who have got bereavement or bereavement. Don't know. Maybe we could ask that of the Sue Ryder person. Yeah. But I think that loss of the newborn or miscarriages is an area that gets coverage, but not quite sure how deep that support is. Yeah.
And the third and last thing was what one of our group is a chaplain, and they were stressing the importance of listening. They'd found the talk there on listening very important.
Yeah, I think certainly we do communication skills work with our medical students, and I think getting them to listen rather than fill the silence is often a difficult thing, partly because that's what they see in practice as well. So I think those listening skills are one of the key things to practice both at undergraduate but also at postgraduate level. Okay, thanks from Dermot. So we've got a couple of other hands. Anybody else put their hand up? Will I ask those as well? So Rebecca, you're next with the hand.
Hi, I'm Rebecca. I'm a hospice chaplain. We were thinking about volunteers, and I was thinking particularly about volunteers in the hospice where I minister, and how they are numerous and very helpful and providing practical support and assistance in the inpatient unit and in day services, but how they seem to spend very little time, just particularly with the inpatients, how they seem to spend very little time with patients, and whether that is to do with governance and policies and safeguarding, and whether that's something that needs to change, and how can that be changed?
And Rebecca, is that a hospice setting you're saying?
Yes.
Yeah, I do think that I think hospices vary, so we can't, this isn't a generalization, but I do think that idea of just being with sometimes is something that isn't part of maybe the hospice tradition. In some respects, because you're in the hospice, it's felt that you've got that support around you, but that being with, certainly for the family, is a normal thing in a hospice, but for a non-family member to be with, I think has been less traditional. I'm sure there's good examples of that happening, but I do think, as I mentioned back when we went to Cologne and when we visited Cologne 10 years ago, for me it was, well, we never do that in the hospice I work in. It kind of didn't happen that if somebody was, as we would say, dying alone, there wouldn't be a sense of, oh, somebody needs to go and sit with that patient in that dying phase. Obviously, people are going in and out a lot more frequently in a hospice setting than perhaps a hospital setting, but I don't think it was part of that culture. So I think it is one of those interesting cultural things, and there may be some good examples of how that works in some places and that people may want to share. Thank you for that. Thank you, Rebecca. And the next is Phil Hughes. Can you just introduce yourself, Phil?
Hi, yeah. My name is Phil Hughes. I'm a chaplain in an acute hospital in Surrey, in the Royal Surrey in Guildford. And we were just talking about self-care and about supervision. As a sort of paid chaplain, that's something I pay for every month, to get supervision for an hour and a half. But I'm just wondering, for volunteers, what setup do you have, John, for volunteers? And can you advise volunteers on where they might get appropriate supervision?
Yeah, I again, it links with the governance of the organisation that's kind of facilitating that volunteer workforce. But I think particularly if you've got people working in end of life, but particularly care for the dying, you are going to see volunteers who maybe get upset by things, who maybe find themselves in difficult situations. That means that in that moment, they need to know what to do and where to go if they're upset by something. That may be to go and talk with the ward staff. It may be back to a volunteer coordinator. But then I think the more regular supervision, and that would be for our volunteers every month, there's a sense of sharing those experiences between each other in that volunteer workforce and learning from each other. And I think that shouldn't be underestimated, the value of those supervision meetings. So I would be strongly encouraging that particularly for this group of volunteers. Is that okay, Phil?
Yeah, no, it's good. I know there are now training courses. I know some clergy I know who've gone through what's called pastoral supervision, and they've been training at colleges for supervising other folks who have a ministry of care and or a pastoral responsibility, whether it be church-based or in a healthcare setting. So I know there are courses now and folks are being trained in pastoral supervision, which is quite a useful thing to know. Yeah,
and I'm aware there's quite a lot of chaplains in the group, but I'm not an expert in this area, but I do think I've heard from various training courses around chaplaincy that I think there's an assumption in society that chaplains know how to be with and deal with situations of death and dying. We expect it to be inherent for chaplains to do that. And perhaps sometimes the training of chaplain and chaplain workers may be enhanced in this area because it's not going to be natural for everybody. So I think just a mention of that, I think, is important. Okay, Tess, we've got a hand up from Tess here. Do you want to introduce yourself, Tess?
Yes, hello. Sorry, I haven't got the camera. It's not working. But some of the things that I've sort of come across personally, having a long history in the NHS, is really respecting religious beliefs, and particularly at the time of end of life. And the use of sort of certain pain relief pathways, which are possibly monitored and admitted in different ways in different departments, and it's almost it's that need to get somebody comfortable at the end of life. But without actually enforcing overdose and death by too much drugs, and that's always been a worry. But there are pathways in place now. But That was one of the things that I was always concerned about for people that didn't want pain relief at the end of life, and how to manage that. But the other area is newborn babies that have been born with very bad, very terminal illness and not seem to be would not survive in life, and how those babies are managed is sometimes a big concern as well. But I know that we're talking 18 years plus, but I just wanted to put that into the equation. Thanks.
Yeah, thanks, Tess, for that. I think you're right, and you'll find in all care settings there should be guidelines and guidance about best use of medications at the end of life, including pain control. I think you point to an interesting scenario for some patients who don't wish to have pain relief. Maybe we might come back to that later. I think that's always it's a challenging situation to find yourself in as certainly a healthcare professional. And I think often there are thoughts, beliefs maybe underpinning that may be good to respect, but also good to acknowledge and discuss further. I've seen a number of patients like that, and I think that there are ways of dealing with that. Again, the babes and the neonates, I think, again, that there is guidance there, but that's not really an area I can talk much more about because that's not an area of my expertise. So, but thanks for that, Tess. Andrew Williams, if you just introduce yourself and share your thoughts.
Yeah, reporting from Breakout Group 4. I'm actually a chaplaincy volunteer in our local, here in Poole, our local hospice, the only volunteer, and I'm fairly new to it, about 5 weeks in. Although I've done end of life chaplaincy with the palliative care team when in people's own homes. But from our group, I'm picking up Dermot's point about resources, a whole range of resources out there. We're learning more about some of them today, and perhaps we need a directory of those. We found the Sue Ryder stuff really interesting, and that led me on to reflect on our current discussions in Poole, in Churches Together, about our concern about direct cremations and the removal of the rite of passage, and possible bereavement for families, etc., by this very heavily marketed service. We have very competitive funeral directors within our Bournemouth, Christchurch and Poole, very effective and efficient. But what's left, and we're looking in Churches Together to try to get a range of resources and train individuals. I mean, that's our ambition, that could be available to assist with that. And that's where I thought the Sue Ryder stuff played in very, very definitely. But also the tender conversations, yes, and the listening, I thought was extraordinarily valuable. Thank you.
Yeah, thanks for that, Andrew, and interested in that work you're doing. I think the direct cremation market is increasing, and we increasingly see that ourselves. And I guess on one level there are benefits, but then that lack of process of bereavement and grief, those things that normally market with a service or something that is at least, or people out at the crematorium, that's taken out and away from people, and how that might affect bereavement, I think is probably not thought through a lot by those who are dying. But I think for those left behind, about how we create spaces in that situation, I think is new territory for most people. Yeah. Thanks for that. Sean's iPad. Can you introduce yourself, Sean?
Yeah, my iPad and I, yes. My name is Sean Davis. I'm a doctor working in palliative care in West London, and my focus has been or my focus in in recent years has been mostly with community provision. And thanking Rebecca for feeding back from our group 8. But one question that I have almost for everyone is the sense, do we feel that there's been some kind of shift in a societal understanding of death and dying, having come through as much of the pandemic as we have? Have we shifted some of the apparent unfamiliarity that we've unfamiliarity with death and dying that we've acknowledged? So it's a kind of question.
That's a nice question. I think if we can get feedback from a couple more people, maybe we can make this slightly brief. Then we can have another discussion centre, another discussion, which I want about fears, concerns, but maybe about pandemic-linked things as well. And then we can do another feedback session. So let's take that maybe into the discussion for everybody. So I've got Teresa next, and I've got John and BHRUT. Teresa.
Hello.
Hi.
Thank you for that. We had a group, or interesting group, of group 1, and there were 2 nurses, 1 lay person, 1 healthcare assistant. And it was interesting that the lay person was a volunteer trained with SVP. And it was interesting to know that there was a choice in where to be placed. So you could be where the setting you wanted to be. Another point that came up was that it isn't easy to be a volunteer necessarily. Training is vital, but it can be difficult. And that led into the question actually I'd asked earlier, which was, in places that have actually got legalized assisted suicide or are considering it, it would be even harder to be a volunteer, perhaps, for them, for those people that wanted to volunteer, knowing that this was the situation. That's what we concluded. 2 of the members were actually in Gibraltar, and there was Spain discussed that's looking at euthanasia. So we thought that it would be difficult to be a volunteer in that situation, or even more difficult.
Yeah, I think, well, my understanding, I know of systems in place around the world. So I've got colleagues in the Netherlands, but also Australia, the state of Victoria, that has legalised physician-assisted suicide. Also colleagues in Belgium where it's legal. I think there, in these situations, there would be a very clear distinction from those patients who are undertaking those kind of procedures and that pathway, as opposed to the majority who would be being normally cared for, I would think. So I don't necessarily think it would complicate the role of volunteers. It may mean if volunteers are engaged in patients earlier on in the last weeks and months of life, then those conversations may occur with volunteers that may cause complexity. But then, at times volunteers may also get questions that are also very hard for them to answer, and they don't know, if they don't know the answer or don't know what to do with that, then they also have to have a support mechanism to know where to go for that. So I think if physician-assisted suicide or euthanasia was legalized in this country, I would hope that we wouldn't then lose a volunteer workforce, but we would certainly need to, they would certainly need to be trained to understand how to deal with those kind of conversations if and when they arose. John, over to you.
We actually just got round to introducing ourselves more than anything, but actually there's some salient points that I think keep coming up that I wanted to sort of maybe just emphasize. The idea of integration in the culture, and John, you've talked about this, there seems to be a bit of a tension. There's legitimate practice, benefits, and something tangible to be offered and received within companionship and volunteering. There seems to be a bit of a tension with that sort of medical model governance, or maybe even that dominance to measure something tangible to gain from it. And I think that gives a bit of a tension with things like legitimizing practice, integration, which is hard. And maybe a second point that's part of that is, I think a big part of this is that normalizing death and those open conversations to feel comfortable to support someone to get peace, comfort, and feel death normalized, which I don't think as a society and maybe as a medical world, we've kind of moved away from that. And Catherine talked about the fix-it approach, which maybe was quite ingrained and quite hard to shift as we try to integrate volunteering and companionship. So there's two sort of salient points that I think keep coming up, is that integration with that medical culture, and then the more sort of holistic normalization of death, which seems to be really core to this, which as a society maybe we've moved away from that thinking.
I think those are important points, John. I think it's partly in the training of volunteers to avoid that medicalization and I might say healthcareization of people, so they don't feel like they're there instead of the nurse. They're not there instead of the nurse. They're there as a community presence. I think that kind of should be what's coming through with that training. But then having said that, I think when we're putting volunteers into a system, whether that be a hospital, a hospice or community, I guess we have a responsibility to make sure that there are that governance about the safety for the volunteer as well as for the people who they are kind of communicating with. And again, always tensions there about how rigorous and how strict that is. And I think for many years, hospices have been kind of reluctant to have people by themselves volunteering in the community because of the risks associated. But I think you could see from Anita's presentation, that is loosening now. And it's quite interesting that some of those volunteers, only a small number, were doing personal care. Well, that would never have happened 10, 20 years ago. So there are ways and there are systems in place that are emerging here to enable more diversification of volunteering. But then we do have that overlay of making sure it's safe for the volunteer and safe for the recipient of that volunteering as well. And that is always going to be a tension in the system. But I think that before it's a barrier, whereas I think now organisations are moving through that and managing that risk as they would see it. So I think we had somebody else to Isabel. That's it, Isabel. Great.
I'll just unmute myself. So I was in group 7 and just I wasn't aware that I was going to be feeding back, but my recollection of it was that everybody was very engaged with the listening presentation, and it was also raised that the Sue Ryder presentation was also very interesting, and particularly so for me because I volunteer on the cruise helpline, supporting people who have been bereaved. So I was very interested to hear about all the work that Sue Ryder is doing. Although a lot of the people I speak to are very elderly and they simply cannot access anything that involves them using a computer. So that's just one thing, but that's the way it is. The one thing I wanted to say was that a lot of the callers we get on cruise, their grief is exacerbated dramatically in some cases by what I would describe as a traumatic death, or a death that hasn't been well supported in all the ways which are being promoted today. And just to say how important any work that we can do to improve the care of the dying will have an immediate knock-on effect on the type of bereavement and grief that people experience, and all that talk that was so brilliant in the listening presentation about tenderness is just so relevant and so important to all stages of, seems to me, the whole process towards death, and actually the after effects on people who have been bereaved. So everything that's gone on today has been very important and interesting to me.
Yeah, I think I would echo what you said there, Isabel. I think that particularly how people die, as I think Cicely Saunders said, lives on with those who follow and in the bereaved. And I think particularly those last hours and days are so important to people. I remember a relative contacted me as he knew I was interested in care of the dying. And he was a middle-aged guy, and his wife was, in her 40s or 50s, so she was quite a young patient, and she'd had quite an aggressive sarcoma. And he said she had the most fantastic medical care, the most fantastic surgical care, the most fantastic oncology care. But when it came to the last days of her life, she had this uncontrolled pain. Yeah, and he said that, because she died the way she did, all the care she had before meant nothing to me. And I kind of felt that was such a powerful statement, that all that front loading we do, if people aren't dying well, the bereaved relatives are left with such a legacy that they never get through. And we know from our own friends and relatives that they can talk about a bereavement. And if it's been if those last hours and days were bad, for whatever reason, and there can be many, many reasons, they will carry that with them throughout their life. I think it's that transformative time. It's that moment of birth and that moment of death holds that same emotional kind of value for us, I think, as human beings. And that's why I think that anything we can do to help support patients, but also relatives in those last hours and days, can make a huge impact on not just how patients die, but on the bereaved relatives' grief and life afterwards. So I think it's a very powerful thing and a powerful kind of service and support that healthcare professionals and volunteers give at this time. Okay, we've got Andrew's going to come back. Before Andrew comes back, I just want to read the chat a second from our group, who just were telling us about the volunteers and about how they're interviewed. And I think this is where I think just like to kind of a bit of a distinction here between we're talking about volunteers. There's this nice phrase called non-kin carers. I don't know whether you've heard about it. I first heard about it from a group in Austria, and kind of non-kin carers are essentially well, it is what it says, but it's not. No, we don't really use this term in English, as it were. But non-kin carers, it's like your neighbour coming in to do your shopping, or like your neighbour coming in to support you. So they're actually not a volunteer, but they're like a non-kin carer. Now, if people are going into somebody's house as a non-kin carer, then they're offering that to somebody, and the person has got to do their own risk assessment and say, yes, that's fine. So it's between those two individuals. When you get an organisation involved in this relationship, then that's when you have more of the formalising of a volunteer with a patient. And as you can see from BHRUT, they do go through DBS checks and health checks, and they are interviewed about their suitability of that role before they are then enabled through training to work with end-of-life patients. And I think that's what I think that seems a reasonable thing that we would expect volunteers to go through in order to deliver this and to be put into our society. So I think that what they're describing there is what you'll find is generally what's followed in most organisations, including hospices, community and hospitals. So thanks for that. Andrew, you're back with a hand.
Just to say, John, in following up the point about dying well or not, this week's Jim Al-Khalidi's Life Scientific interview was with someone whose name I've forgotten, but I thought she was quite remarkable for the research she'd done into re-imaging traumatic situations. And I thought that that's got to be applicable to basically what is a post-traumatic stress disorder of that image. Because I was talking to someone this week, actually, who was with her dying sister, both of them young, and she described the death of their father in a ward and how traumatic that was when the life support was switched off, and the reassurance her sister is getting as she dies in a hospice of being with her family and friends around her, and in the privacy of a single room, but with the she's still reliving that situation of her father's death, and interestingly was reassured because she felt when she was sleeping, when the family thought she was sleeping, she could hear them, and she was being reassured that the messages they were able to give to their father on life support, rightly or wrongly, but it's giving her comfort to feel that he was actually hearing them. But I just thought that Jim Al-Khalidi program would be worth me going back to find out who this person is, but someone in the room probably knows anyway. Thanks, John.
Thanks for that. Yeah, I have to say that I think things have moved. Well, I think, and we also have more evidence of how people, particularly in the hospital setting, are cared for and how people are dying in that sector. Certainly when I started in palliative care, which was some years ago now, and I went into King's College London, and when I was there as a trainee, there were no palliative care consultants in King's College. I was supervised by an oncologist and a pain doctor. But actually what you saw in that hospital was patients dying distressed and relatives sat at the bedside who were quite distraught, hadn't been communicated with, and often quite angry. So that was kind of the role of a hospital palliative care person maybe 25 years ago. And when I went to Liverpool, the University Hospital, it was the same there. That's kind of what was almost normal in our hospitals in this country. And I do think, it's a quarter of a century, 25 years later, I think those situations are now more the exception than the normal. I think we've done a huge amount of training. I hope those of you in hospitals see that. We have a national audit done every year into how care is delivered in our hospitals. We have education and training, often mandatory now in our hospitals. So we've come an awful long way. We're never perfect. We'll always get the isolated poor practice, but I think in those 25 years, things have moved on considerably. And I think an idea of the support of a volunteer workforce into the hospital situation, also hospice and community, is a real addition to giving excellent end-of-life care. So I think we should be upbeat about what's going on in our society and in our care for the dying, and really look to how we can enhance the role of volunteers. And just a big shout out to the St. Vincent de Paul activity that's beginning to take shape and develop over these next few months and years. So, well, I think that's been really fascinating. I hope you've enjoyed some of that in your discussion. We weren't quite sure of the number of people in the room that were going to be, but I think those reflections and those thoughts have been really valuable. So I hope you've enjoyed that session. I think we can break off now.